So for vaginal tumors, squamous cell carcinoma is most frequently tested where they'll ask you the etiology of it. Okay, so they'll say, where did this tumor come from, or how did this tumor come about? And they'll want you to know that it's secondary to squamous cell carcinoma of the cervix. Okay, for some reason, this is the detail they love assessing regarding SCC of the vagina, where it started at the cervix and it migrated inferiorly. Now, for clear cell adenocarcinoma, almost always they'll mention diethylstilbestrol exposure in utero, or they'll mention that a woman has a clear cell adenocarcinoma of the vagina. Then they'll ask the most likely etiology of it, and it will be that she was exposed to diethylstilbestrol in utero. Okay, so clear cell adenocarcinoma tends to occur in women in their 30s or 40s, and it was actually due to their mothers 30 or 40 years ago who had taken DES to allay vaginitis symptoms. The drug's not given anymore, clearly, but women would take this drug sometimes while pregnant, and then 30 or 40 years later, their daughters have clear cell adenocarcinoma of the vagina. So you need to remember DES exposure in utero is what is responsible for this tumor. Now, sarcoma botryoides is a rhabdomyosarcoma variant. So classically, they'll mention this as bunches of grapes protruding from the vagina in an infant. Okay, so whereas we talked about yolk sac tumor as occurring in infants, under the age of 3 for ovarian tumors, if they mention a vaginal tumor and it's an infant, you want to think sarcoma botryoides. So this bunches of grapes is actually extremely high yield. Now, apart from just being a colloquial phrase, it literally does show up in questions. So I'll mention bunches of grapes, these aggregate clusters protruding from the vagina, and they're referring to sarcoma botryoides. Recall that rhabdomyosarcoma refers to a malignant neoplasm of skeletal muscle. Leiomyoma or leiomyosarcoma be smooth muscle, for instance, whereas rhabdomyosarcoma, you'll see spindle-shaped cells. So spindle-shaped cells is what should give it away that it's a rhabdomyosarcoma, and Desmond positive refers to muscle cells. Now, rarely will you have to diagnose a rhabdomyosarcoma, sarcoma botryoides, via specifically seeing spindle-shaped or Desmond positive as terms in the vignette, but occasionally a vignette can be vague, and these terms help you clinch the diagnosis. Desmond especially tends to not be exceedingly high yield, but it is something that you should be aware of. Refers to muscle. It is a muscle protein. But once again, bunches of grapes is what you need to take away from this, and the fact that this occurs in an infant. So for breast pathology, we have this illustration here. Now, the USMLE, it'd be very rare for them to show you a picture like this and then just specifically say what occurs at which location, which we do this for you to help you understand the pathology of the breast with conditions such as Paget's disease occurring most superficially at the nipple, and working our way down with lobular and ductal carcinomas, and going to fibrocystic change and medullary carcinoma as we get deeper. So these pathologies that we'll discuss, but in general, this image can help you have an idea of the structure of the breast, and now we'll talk about what can go wrong. Fibroadenoma. Now, this is the most common tumor in women that occurs in the breast, and it's classically younger women. Okay, if they gave you a vignette and they mentioned a 72-year-old female, you wouldn't typically think fibroadenoma, but this will be frequently tested as a young woman who she's palpating her breast and she feels a solitary lesion. Okay, that'll be the key. She feels a solitary lesion, and it's rubbery, it's motile, and it's not fixed to any underlying tissue, and they'll want to know what it is, and it's a fibroadenoma. Okay, so the main confusion sometimes that students have is mixing this up with fibrocystic change, which we'll talk about. Fibrocystic change tends to fluctuate with menses. It tends to have tenderness associated with it. It can be bilateral, whereas fibroadenoma is that classic solitary lesion, that classic mobile mass in a breast of a young woman. So intraductal papilloma. Now, almost always, if they give you a vignette of intraductal papilloma, they'll mention bloody nipple discharge. Now sometimes even if they don't give you a very specific description, but they mention bloody nipple discharge, intraductal papilloma should be the first differential that comes to mind. Not 100% of the time. Okay, so if they mention a stellate morphology to cells in conjunction with bloody nipple discharge, you'd want to think more of an invasive process. That stellate word referring to more invasive, but I'd say at least 80 to 90% of the time if they mention a bloody nipple discharge in a woman who doesn't seem to have an otherwise severe condition, she doesn't have this lymphadenopathy of the cervical region, or she doesn't have B symptoms, okay, so she doesn't have fever, night sweats, weight loss. She just seems otherwise fine, nothing too out of the ordinary, but yet she just happens to have bloody nipple discharge. So you want to think intraductal papilloma, this benign tumor, if that's the case. And you can see on the histology here, it almost looks very papillary. You see these branching structures, almost like flower-like. So that's intraductal papilloma of the breast. Now, phyllodes tumor, also known as cystosarcoma phyllodes. Now, the highest yield thing you need to know about this is that it's very fast-growing and it can get very large very quickly. Now, it's not a very common tumor, but if you ever hear of someone who has breast cancer and they say, oh, it grew extremely quickly and it got very large very fast, they're possibly referring to a phyllodes tumor, the cystosarcoma phyllodes, and it has a leaf-like pattern. So this word phyllodes has a Greek derivative that refers to leaves. So this leaf-like pattern, it's large and it's fast-growing, and it's a phyllodes tumor. So for malignant breast tumors, this is information that you need to commit to memory. So the USMLE tests expression of hormonal receptors, the progesterone estrogen receptors, and it also tests the expression of the epidermal growth factor receptor, HER2/neu, also known as CERBB2. Now, in your mind, you have to have EGF receptor, HER2/neu, and CERBB2 all as synonymous. You need to have these terms as synonymous. Now, the USMLE likes you to know that estrogen and progesterone receptor positivity improve prognosis, whereas presence of HER2 receptor positivity worsens prognosis. And they'll ask you that directly. They'll say, which of the following is associated with worsened prognosis? And they'll say things such as, night sweats, fever, weight loss, cervical lymphadenopathy. They'll say these types of things, like mitotic index, all appealing answers, but they mention HER2 receptor positivity, that's worsened prognosis. Same thing for, has the tumor spread to the lymph nodes yet? Recall that stage is more important than grade when considering prognosis. So stage would be the size of the tumor, is there spread to lymph nodes, and has it metastasized? Doesn't matter if you have a high grade. You can have lack of differentiation of the tumor itself, which would imply malignant potential, anaplastic nature. But if they ask you for the most important prognostic factor, it's, has the tumor spread to the lymph nodes yet? Because if it has spread to the lymph nodes, prognosis is drastically worsened. It's even more important than HER2 receptor positivity. So commit this information to memory. And also, it would be good to note that the estrogen and progesterone receptor positivity, one of the reasons for the improved prognosis is because we have drugs that can treat these cancers fairly well, such as raloxifene or tamoxifen, these selective estrogen receptor modulators. HER2 receptor positivity, we have Herceptin, which is also known as trastuzumab, so it's a monoclonal antibody against this receptor. But even still, with this treatment, prognosis is worsened. So for ductal carcinoma in situ, it's considered malignant, although it hasn't invaded. It's in situ, it's yet to have penetrated the basement membrane, but it's still malignant. It's got the potential, the possibility to metastasize. And one of the USMLE favorites is that they'll show you a picture of like a reddened or erythematous nipple, which is reflective of Paget's disease of the nipple. And then they'll ask you for the cancer that's most likely underlying the nipple, and the answer is ductal carcinoma in situ. They'll tell you that a patient has a nipple that's cracked and red and inflamed. You have these different differentials going off in your head, such as mastitis. Then they'll say that there's an underlying mass that is a tumor/cancer, and they'll want to know what it is. and the answer is ductal carcinoma in situ when they're referring to Paget's disease of the breast. That's the most common answer for that. And what differentiates this from ductal carcinoma that invades, so the invasive ductal carcinoma, is that for the DCIS, it's yet to have penetrated the basement membrane, okay? So you have this histology that shows these enlarged ducts, but yet we don't have penetration of a basement membrane. Now, for comedocarcinoma, there's literally one thing you need to know, and that it's cheese-like or caseous. Now, recall that caseous necrosis is cheese-like. So you see that with tuberculosis, systemic fungi, nocardia. But this cheese-like necrosis, and this is a classic image, equals comedocarcinoma on USMLE. Now, Paget's disease of the breast, which we just mentioned, now this would be the example of a photo that they'd show you where there's this red erythematous lesion of the nipple, and right away it's Paget's disease of the breast, okay? Most likely. Could be other things, could be an inflammatory carcinoma, mastitis, but Paget's disease of the breast is classically this photo. Ductal carcinoma in situ underlies it most frequently, and an important histological finding, not exceedingly high yield, but it does show up in maybe about a quarter of Paget disease questions, is they'll mention in the vignette literally large cells in the epidermis with clear halos. And it's something you've either heard or you haven't. It's not the most obvious in terms of its histological description, but if they mention large cells in the epidermis with clear halos, okay, these clear halos, that's referring to Paget disease. And you can see in the histological picture on the left these large cells with clear halos. Now this is the invasive form of ductal carcinoma in situ. It's penetrated the basement membrane. So the one detail that can really set this apart from intraductal papilloma when you have bloody nipple discharge is the stellate morphology of the cells. Now we said before, if they give a relatively vague vignette, a woman, she seems to be otherwise in a non-severe state, relatively composed, no fever, night sweats, weight loss, no lymphadenopathy, and she has bloody nipple discharge, you want to think intraductal papilloma. However, if they give you a vignette, they say bloody nipple discharge, and you have a woman who's cachectic, she's lost 20 kilograms in the past 6 months, she's had night sweats and weight loss, she seems to have this condition that reflects underlying malignancy, and she has bloody nipple discharge, and or if they mention the stellate morphology of the cells, the answer is invasive ductal carcinoma for what is underlying the bloody nipple discharge. And also just important to mention that invasive ductal carcinoma is the most common invasive malignant breast cancer. So when all else fails and you're just, in a decision to pick one of the answers, just remember that invasive ductal carcinoma is most common. Don't confuse this with invasive lobular carcinoma. Now, this is one of the USMLE tested favorites for what's bilateral. Now, recall that for the ovaries, for example, we have the serous cystadenoma or serous cystadenocarcinoma. But for the breast, they like the invasive lobular carcinoma. So if they tell you that a patient has a bilateral breast cancer, this should be on the top of your differential. So even though invasive ductal carcinoma is more common overall, if they say bilateral, this should now be ahead of invasive ductal as your answer. And this linear pattern or rows of cells tends to be what's described in USMLE questions when it comes to invasive lobular carcinoma. So if they said these enlarged ducts, they say the word duct or stellate morphology, you'd think ductal carcinoma. But if they say linear pattern, rows of cells, you want to think lobular carcinoma. So linear starts with L, as does lobular. Now medullary carcinoma, classically soft and fleshy. These are two buzzwords that you need to commit to memory. So similar to comedocarcinoma, which cheese-like or caseous were the buzzwords you needed to know, for medullary carcinoma, it's soft and fleshy. Has a lymphocytic infiltrate, but nevertheless, they'll tell you in pretty much every question regarding medullary carcinoma that it's soft and fleshy. So the USMLE is not expecting you to be full-blown pathologists, but this is a detail that they will mention in the vignette when it comes to this cancer. Now, inflammatory carcinoma. Now, this sometimes can be confused with mastitis or infection because it can appear like an infection in the vignette. They'll mention an red, inflamed area. They tell you the area is red and inflamed, and there's no reason why you shouldn't think infection is a possibility. But the answer is inflammatory carcinoma if they mention the modeling of the skin. Okay, so this is peau d'orange, the modeling of the skin, because you have your Cooper's ligaments, which are holding the tissue together, concomitant to lymphadenopathy. So when you have this defective lymph drainage, but you have intact tissue because the ligaments are fine, it produces this modeling of the skin. So if they say there's a red inflamed area, and then that there's modeling of the skin, or this pruning type appearance of the skin, they're actually referring to inflammatory carcinoma, and it can sometimes be confused with Paget disease, because the Paget disease has that erythematous nipple. So it has this red appearance to the nipple, but once again, the peau d'orange is how you differentiate that from Paget disease. And this is why it also helps to know, for instance, that Paget disease has those large cells with clear halos. Because if they mention that detail in the question and you weren't sure, that would help you know it's Paget disease. Whereas if they say modeling of the skin, you know it's inflammatory carcinoma. So for the flash quiz, what is the likely diagnosis of bloody nipple discharge in a benign presentation? Intraductal papilloma. They give you a relatively benign presentation, no night sweats, fever, or weight loss, no lymphadenopathy, and they mention bloody nipple discharge and ask for the underlying cancer. The answer is intraductal papilloma. And if, in contrast, if they mentioned stellate morphology to the cells, or they did mention B symptoms, night sweats, fever, weight loss, and lymphadenopathy, you would instead want to think invasive ductal carcinoma.